So special tests at the shoulder is an incredibly controversial topic. In this video, I'm going to give you what tests you should keep, what tests you should potentially forget, but also some top tips on how to get the most out of your assessment. Let's dive in. Hey guys, Khalid here. Welcome back to Clinical Physio. So we know that the shoulder is one of those joints that physiotherapists have lots of questions about, especially in the early parts of their career. So as well as some special tests, I'd really like to give you some simple tips to help with your shoulder differential diagnosis and assessment. So top tip number one, tests that I use all the time with every shoulder patient I assess: resisted external rotation and resisted internal rotation. Quite simply here, we're going to ask the patient to move into the external rotation or internal rotation movements, and the examiner is going to resist that movement. So why are these tests important? Well, they're really good for looking at muscular and tendon issues. So we're primarily thinking about a rotator cuff tendinopathy or a rotator cuff tear. Now, in the case of a tendinopathy, we might find that these tests are painful for the patient because we're getting them to use the tendons which are not very happy. We may also find that there's an element of reduced power there. So it might be that they can't exert quite as much strength on the Oxford scale between 0 and 5 compared to the other side. When we're thinking about our rotator cuff tears, you may find that the patient is able to demonstrate very little strength into those movements. It might be that you find them cheating. They might try and use shoulder abduction. They may try and move their trunk in order to try and influence the movement more. So those are some top tips to remember. And I find that these tests are much more useful than things like the drop arm test or the lift off test, other tests in the past that we may have used for rotator cuff tears. More on those in one of my other top tips later. So top tip number 2 is to learn your SLAP cluster tests. So cluster testing is where we join different tests together, and the joint outcome of those tests is much more valid than the outcome of one test by itself. Now, when it comes to SLAP lesions, the 3 tests that you can cluster together are biceps load tendon test 1, biceps load tendon test 2, and O'Brien's test. So how do we do them? Well, for biceps load test 1 and 2, the patient is normally placed in a supine position. Now for load test 1, the examiner will passively bring the shoulder into a 90-degree abduction position with external shoulder rotation and full supination at the forearm. The examiner then asks the patient to flex their elbow with the examiner resisting the movement. If it produces a deep ache in the shoulder, that's a positive on this test and may indicate a SLAP lesion. Biceps load test 2 is exactly the same, except the arm is placed in 120 degrees of abduction with the external rotation and full supination. Once again, resist the movement and you're looking for that deep ache as a positive sign. So for O'Brien's test, the patient is normally sat on the edge of the bed with their shoulder in approximately 90 degrees of flexion and 10 degrees of horizontal adduction. Here, their arm is fully internally rotated and they are asked to push upwards against the examiner's resistance. The test is then repeated, but with the arm now in a fully externally rotated position. And the idea is that if the first internally rotated position was painful, but the second externally rotated position was not painful, this is positive for a SLAP tear. So to demonstrate just how powerful cluster testing is, Clark et al. 2019 showed that when you group these 3 tests together, it provides a sensitivity and a specificity of 99% for investigating SLAP tears. So top test number 3 is the scarf or horizontal adduction test. Here we're looking for pathology of the acromioclavicular joint between the acromion and the clavicle. Here we ask the patient to have a seated position, and then the examiner passively adducts the patient's shoulder and arm across their body. Now when we do this, we're looking to see if it reproduces pain at the acromioclavicular joint itself. If it does, this is a positive sign for ACJ pathology. So crucially with this test, where does your patient feel their pain? If they're saying that it's at the anterior shoulder or the lateral arm, it gives us less indication that our patient has ACJ pathology. However, if we do the test and the patient says, yep, that's my pain, it's right there on the top of my shoulder, that's where we're looking at the ACJ. And Powell and Hoybretz from 2006 reported good sensitivity and specificity with this test, sensitivity of 77 to 100% and specificity of 79%. So top tip number 4, which shoulder tests do we not use as much anymore? This is something that's really come to the forefront of shoulder assessment. We find that special tests at the shoulder aren't quite that special. So for example, the Hawkins and Kennedy test. This is where we position the patient's arm in a really weird position. And in fact, most patients with acute shoulder pain will probably find this test painful. Does it truly tell us which structure's involved? No, it probably doesn't, because so many pathologies will get irritated with this test. What about rotator cuff tests such as the drop arm test or the lift off test? Now I have to admit, I did used to use these tests in practice, but then we started thinking the drop arm test, it actually is probably quite irritable to drop someone's aggravated shoulder from a height and expect them to catch it. Similarly with the lift off test, we place their arm in a really challenging position behind their back and then ask them to push away. Do these tests truly tell us if the rotator cuff is torn? Or actually, would someone with a very acute rotator cuff tendinopathy react in exactly the same way? The tests, unfortunately, don't tell us as much as we previously thought. What about the anterior apprehension test for instability? Well, here we passively move the shoulder into full abduction and external rotation, which is a position that an unstable shoulder, one that may have dislocated in the past, really won't like. Does this truly tell us if they're unstable, or actually does it just reduce the patient's confidence in the physiotherapist as they start thinking to themselves, why on earth are they moving my shoulder into that place it's going to dislocate? And that brings me on to top tip number 5. Rather than doing loads of special tests, prioritize your subjective assessment. Rather than going through lots of tests and confusing yourself, instead, really listening to your patient's story, asking some really good questions and building a great picture of what your patient's shoulder sounds like is a really good way to go. And I find a really simple question I ask myself at the end of my subjective assessment is, what is my patient's main problem? Is it the main problem is stiffness? Okay, we might be thinking of a frozen shoulder or an osteoarthritis. Is their main problem weakness? Okay, we might be thinking of a rotator cuff tear or a nerve injury, for example. Is their main problem a really acute, irritable shoulder with no history of trauma? Okay, we might be thinking about something like a rotator cuff tendinopathy or a long head of biceps tendinopathy. Ultimately, asking these questions and getting a really good history will give you so much more than all the special tests. And if you want to find out more about this, then you can check out our full webinar, Differential Diagnosis of the Shoulder, in the link in the description below. And so that completes this video. If you want YouTube videos of some of those key special tests, you can find them in the description below. Otherwise, we'd love you to support our channel by smashing that like button and subscribing to the channel. Otherwise, we've got loads on our Instagram account at Clinical Physio, or on our website, clinicalphysio.com. My name's Khalid. Thank you so much for watching. See you soon here on Clinical Physio.